Lewis's Medical Surgical Nursing, 11th edition. Chapter 44, Assessment, Urinary System. Adequate kidney function is essential to health. If a person has complete kidney failure and treatment is not provided, death is inevitable. This chapter discusses the structures and functions, assessment and diagnostic studies of the urinary system. Structures and functions of urinary system. The upper urinary system consists of two kidneys and two ureters. The lower urinary system consists of a urinary bladder and urethra. Urine is formed in the kidneys, drains through the ureters to be stored in the bladder, and then passes out of the body through the urethra. Kidneys. The kidneys are the principal organs of the urinary system. The primary functions of the kidneys are to 1. Regulate the volume and composition of extracellular fluid, ECF, and 2. Excrete waste products from the body. The kidneys also function to control BP, make erythropoietin, activate vitamin D, and regulate acid-base balance. Macrostructure. The paired kidneys are bean-shaped organs located retroperitoneally behind the peritoneum on either side of the vertebral column at about the level of the 12th thoracic T12 vertebra to the 3rd lumbar L3 vertebra. Each kidney weighs 4 to 6 ounces, 113 to 170 grams, and is about 5 inches, 12.5 centimeters long. The right kidney, positioned at the level of the 12th rib, is lower than the left. An adrenal gland lies on top of each kidney. Each kidney is surrounded by a considerable amount of fat and connective tissue that cushions, supports, and helps the kidney maintain its position. A thin, smooth layer of fibrous membrane called the capsule covers the surface of each kidney. The capsule protects the kidney and serves as a shock absorber if this area is traumatized from a sudden force or strike. The hilus on the medial side of the kidney serves as the entry site for the renal artery and nerves and as the exit site for the renal vein and ureter. The parenchyma is the actual tissue of the kidney. The outer layer of the parenchyma is the cortex, and the inner layer is the medulla. The medulla consists of a number of pyramids. The apices, tops of these pyramids, are called the papillae, through which urine passes to enter the calyces. The minor calyces widen and merge to form major calyces, which form a funnel-shaped sac called the renal pelvis. The minor and major calyces transport urine to the renal pelvis. From there, it drains through the ureter to the bladder. The renal pelvis can store a small volume of urine. Microstructure. The nephron is the functional unit of the kidney. Each kidney has around 1 million nephrons. Each nephron is composed of the glomerulus, Bowman's capsule, and a tubular system. The tubular system consists of the proximal convoluted tubule, loop of Henle, distal convoluted tubule, and collecting tubules. The glomerulus, Bowman's capsule, proximal tubule, and distal tubule are in the cortex of the kidney. The loop of Henle and collecting tubules are in the medulla. Several collecting tubules join to form a single collecting duct. The collecting ducts eventually merge into a pyramid that empties via the papilla into a minor calyx. Blood supply. Blood flow to the kidneys, around 1,200 milliliters per minute, accounts for 20 to 25% of the cardiac output. Blood reaches the kidneys via the renal artery, which arises from the aorta and enters the kidney through the hilus. The renal artery divides into secondary branches and then into still smaller branches, each of which forms an afferent arteriole. The afferent arteriole divides into a capillary network, the glomerulus, which is a collection of up to 50 capillaries. The capillaries of the glomerulus unite in the efferent arteriole. This efferent arteriole splits to form a capillary network, the peritubular capillaries, which surround the tubular system. All peritubular capillaries drain into the venous system. The renal vein empties into the inferior vena cava. Physiology of urine formation. Urine formation is the outcome of a complex multi-step process of filtration, reabsorption, secretion, and excretion of water, electrolytes, and metabolic waste products. Although urine formation is the result of this process, the primary functions of the kidneys are to filter the blood and maintain the body's internal homeostasis. Glomerular function. Urine formation begins at the glomerulus, where blood is filtered. The glomerulus is a semi-permeable membrane that allows filtration. The hydrostatic pressure of the blood within the glomerular capillaries causes a portion of blood to be filtered across the semi-permeable membrane into Bowman's capsule. There, the filtered portion of the blood, glomerular filtrate, begins to pass down to the tubule. Filtration is more rapid in the glomerulus than in ordinary tissue capillaries because the glomerular membrane is porous. The glomerular filtrate is similar in composition to blood except that it lacks blood cells, platelets, and large plasma proteins. Under normal conditions, capillary pores are too small to allow the loss of these large blood components. However, in many kidney diseases, capillary permeability increases, which allows plasma proteins and blood cells to pass into the urine. The amount of blood filtered each minute by the glomeruli is expressed as the glomerular filtration rate, GFR. The normal GFR is about 125 milliliters per minute. The peritubular capillary network reabsorbs most of the glomerular filtrate before it reaches the end of the collecting duct. Therefore, only 1 milliliter per minute, on average, is excreted as urine. Tubular function. The tubules and collecting ducts are responsible for the reabsorption of essential materials and excretion of non-essential ones. They carry out these functions by reabsorption and secretion. Reabsorption is the passage of a substance from the lumen of the tubules through the tubule cells and into the capillaries. This process involves both active and passive transport mechanisms. Tubular secretion is the passage of a substance from the capillaries through the tubular cells into the lumen of the tubule. Reabsorption and secretion cause many changes in the composition of the glomerular filtrate as it moves through the entire length of the tubule. In the proximal convoluted tubule, about 80% of the electrolytes are reabsorbed. Normally, this includes all glucose, amino acids, and small proteins. As reabsorption continues in the loop of Henle, water is conserved, which is important for concentrating the filtrate. The descending loop is permeable to water and moderately permeable to sodium, urea, and other solutes. In the ascending limb, chloride ions are actively reabsorbed, followed by passive reabsorption of sodium ions. About 25% of the filtered sodium is reabsorbed in the ascending limb. Two important functions of the distal convoluted tubules are final regulation of water balance and acid-base balance. Antidiuretic hormone, ADH, is needed for water reabsorption in the kidney and is important in water balance. ADH makes the distal convoluted tubules and collecting ducts permeable to water. This allows water to be reabsorbed into the peritubular capillaries and eventually returned to the circulation. Osmoreceptors in the anterior hypothalamus detect decreases in plasma osmolality. These osmoreceptors send neural input to superoptic nuclei cells in the hypothalamus. These superoptic nuclei cells have neuronal axons that end in the posterior pituitary gland and act to inhibit secretion of ADH. In the absence of ADH, the tubules are essentially impermeable to water. Thus, any water in the tubules leaves the body as urine. Aldosterone, released from the adrenal cortex, acts on the distal tubule to cause reabsorption of Na plus and water. In exchange for Na plus, potassium ions K plus are excreted. The secretion of aldosterone is influenced by both circulating blood volume and plasma concentrations of Na plus and K plus. Acid-base regulation involves reabsorbing and conserving most of the bicarbonate, HCO3 negative, and secreting excess hydrogen ions, H+. The distal tubule has different ways to keep the pH of ECF within a range of 7.35 to 7.45. Myocyte cells in the right atrium secrete a hormone, atrial natriuretic peptide, ANP, in response to atrial distension from an increase in plasma volume. ANP acts on the kidneys to increase sodium excretion. At the same time, ANP inhibits renin, ADH, and the action of angiotensin II on the adrenal glands, thereby suppressing aldosterone secretion. These combined effects of ANP result in the production of a large volume of dilute urine. ANP also causes relaxation of the afferent arteriole, thus increasing the GFR. The renal tubules are also involved in calcium balance. The parathyroid gland releases parathyroid hormone, PTH, in response to low serum calcium levels. PTH maintains serum calcium levels by causing increased tubular reabsorption of calcium ions, Ca2+, and decreased tubular reabsorption of phosphate ions, PO42 negative. In kidney disease, the effects of PTH may have a major effect on bone metabolism. Vitamin D is a hormone that we obtain in the diet or synthesized by the action of ultraviolet radiation on cholesterol in the skin. These forms of vitamin D are inactive and go through two more steps to become metabolically active. The first step occurs in the liver. The second step occurs in the kidneys. Active vitamin D is essential for the absorption of calcium from the gastrointestinal GI tract. The patient with kidney failure, also called renal failure, will have a deficiency of the active metabolite of vitamin D and problems with calcium and phosphate balance. In summary, the basic function of nephrons is to cleanse blood plasma of unnecessary substances. After the glomerulus has filtered the blood, the tubules select the unwanted from the wanted portions of tubular fluid. Essential constituents are returned to the blood, and dispensable substances pass into the urine. Other functions of kidneys. The kidneys participate in red blood cell RBC production and BP regulation. Erythropoietin is a hormone made in the kidneys and secreted in response to hypoxia and decreased renal blood flow. Erythropoietin stimulates RBC production in the bone marrow. A deficiency of erythropoietin occurs in kidney failure, leading to anemia. Renin is important in the regulation of BP. Renin is made and secreted by the kidney's juxtaglomerular cells. Renin is released into the bloodstream in response to decreased renal perfusion, decreased arterial BP, decreased ECF, decreased serum Na+ concentration, and increased urinary Na+ concentration. The plasma protein angiotensin from the liver is activated to angiotensin 1 by renin. Angiotensin 1 is then converted to angiotensin 2 by angiotensin converting enzyme, ACE. ACE is found on the inner surface of all blood vessels, with especially high levels in the vessels of the lungs. Angiotensin 2 stimulates the release of aldosterone from the adrenal cortex. This causes Na+ and water retention, leading to increased ECF volume. Angiotensin 2 also causes increased peripheral vasoconstriction. An elevated BP inhibits renin release. Excessive renin production caused by impaired renal perfusion may be a contributing factor in causing hypertension. Most body tissues synthesize prostaglandins, PGs, from the precursor arachidonic acid in response to appropriate stimuli. In the kidney, PG synthesis, mainly PGE2 and PGI2, occurs primarily in the medulla. These PGs have a vasodilating action, thus increasing renal blood flow and promoting Na+ excretion. They counteract the vasoconstrictive effect of substances such as angiotensin and norepinephrine. Renal PGs may have a systemic effect in lowering BP by decreasing systemic vascular resistance. The significance of renal PGs is related to the kidney's role in causing hypertension. In renal failure with a loss of functioning tissue, these renal vasodilator factors are also lost, which may contribute to hypertension. Ureters. The ureters are tubes that carry urine from the renal pelvis to the bladder. Each ureter is about 10 to 12 inches long and 0.08 to 0.3 inches in diameter. Arranged in a mesh-like outer layer, circular and longitudinal smooth muscle fibers contract to promote the peristaltic one-way flow of urine through the ureters. Distension, neurologic and endocrine influences, and drugs can affect these muscle contractions. The narrow area where each ureter joins the renal pelvis is the ureteropelvic junction, UPJ. Subsequently, the ureters insert into either side of the bladder base at the ureterovesical junctions, UVJs. Because the ureteral lumens are narrowest at the junctions, the UPJ and UVJ are often sites of obstruction. The narrow ureteral lumens can be easily obstructed internally, e.g., urinary stones, or externally, e.g., tumors, adhesions, inflammation. Sympathetic and parasympathetic nerves, along with the vascular supply, surround the mucosal lining of the ureters. Stimulation of these nerves during passage of a stone may cause acute, severe pain termed renal colic. Because the renal pelvis holds only 3 to 5 milliliters of urine, kidney damage can result from a backflow of more than that amount of urine. The UVJ relies on the ureter's angle of gallbladder insertion and muscle fiber attachments with the bladder to prevent the backflow reflux of urine, which predisposes a person to an ascending infection. The distal ureter enters the bladder laterally at its base, courses along obliquely through the bladder wall for about 1.5 centimeters, and intermingles with muscle fibers of the bladder base. Circular and longitudinal bladder muscle fibers adjacent to the embedded ureter help secure it. When bladder pressure rises, e.g. during voiding or coughing, muscle fibers that the ureter shares with the bladder base contract first, promoting ureteral lumen closure. Next, the bladder contracts against its base, ensuring UVJ closure and prevention of urine reflux through the junction. Bladder. The urinary bladder is located behind the symphysis pubis and anterior to the vagina and rectum. Its primary functions are to serve as a reservoir for urine and to eliminate waste products from the body. Like the stomach, the bladder is a stretchable, sac-like organ that contracts when it's empty. The trigone is the triangular area formed by the two ureteral openings and bladder neck at the base of the bladder. The trigone is attached to the pelvis by many ligaments and does not change its shape during bladder filling or emptying. The bladder muscle, detrusor, is composed of layers of intertwined smooth muscle fibers. These fibers are capable of considerable distension during bladder filling and contraction during emptying. It is attached to the abdominal wall by an umbilical ligament, the urachus. Because of this attachment, as the bladder fills, it rises towards the umbilicus. The dome and the anterior and lateral aspects of the bladder expand and contract. Normal adult urine output is around 1,500 milliliters per day, which varies with food and fluid intake. The volume of urine at night is less than half of that formed during the day because of hormonal influences, e.g. ADH. This diurnal pattern of urination is normal. Typically, a person will urinate 5 or 6 times during the day and occasionally at night. On average, 200 to 250 milliliters of urine in the bladder cause moderate distension and the urge to urinate. When the quantity of urine reaches 400 to 600 milliliters, the person feels uncomfortable. Bladder capacity varies with the person, but generally ranges from 600 to 1,000 milliliters. Evacuation of urine is termed urination, micturition, or voiding. The bladder has the same mucosal lining as that of the renal pelvises, ureters, and bladder neck. The bladder is lined by transitional cell epithelium referred to as the urothelium. Unique to the urinary tract, the urothelium is resistant to absorption of urine. This means that after waste products made by the kidneys have left the kidneys, they cannot be reabsorbed in the urinary system. Microscopically, urothelium is also several cells deep. However, as urine enters the bladder, these cells can stretch to accommodate filling. As the bladder empties, the urothelium resumes its multicellular layer formation. Transitional cell cancers in one section of the urinary tract can easily metastasize to other urinary tract areas given that the mucosal lining throughout the urinary tract is the same. Cancer cells may move down from upper urinary tract cancers and embed in the bladder, or large bladder tumors can invade the ureter. Cancer recurrence within the bladder is common. Urethra. The urethra is a small tube that incorporates the smooth muscle of the bladder neck and extends to the striated muscle of the external meatus. The urethra's primary functions are to 1. Control voiding, and 2. Serve as a conduit for urine from the bladder to the outside of the body during voiding. The female urethra is 1 to 2 inches long and lies behind the symphysis pubis but anterior to the vagina. The male urethra, which is about 8 to 10 inches long, starts at the bladder neck and extends the length of the penis. Urethrovesical unit. Together, the bladder, urethra, and pelvic floor muscles form the urethrovesical unit. Voluntary control of this unit is defined as continence. Stimulating and inhibiting impulses are sent from the brain through the thoracolumbar T11 to L2 and sacral S2 to S4 areas of the spinal cord to control voiding. Bladder distension stimulates stretch receptors within the bladder wall. Impulses are transmitted to the sacral spinal cord and then to the brain, causing a desire to urinate. If you cannot void at a given time, inhibitor impulses in the brain are stimulated and transmitted back through the thoracolumbar and sacral nerves innervating the bladder. In a coordinated fashion, the detrusor muscle accommodates to the pressure, does not contract, while the sphincter and pelvic floor muscles tighten, contract, to resist bladder pressure. If you can void, cerebral inhibition is voluntarily suppressed. Impulses are transmitted via the spinal cord for the bladder neck, sphincter, and pelvic floor muscles to relax and for the bladder to contract. The sphincter closes and the detrusor muscle relaxes when the bladder is empty. Any disease or trauma that affects the function of the brain, spinal cord, or nerves that directly innervate the bladder, bladder neck, external sphincter, or pelvic floor can affect bladder function. These conditions include diabetes, MS, paraplegia, and tetraplegia, quadriplegia. Drugs affecting nerve transmission can affect bladder function. Gerontologic considerations. Effects of aging on urinary system. Anatomic changes in the aging kidney include a 20 to 30% decrease in size and weight between ages 30 and 90 years. By the 7th decade of life, 50% of glomeruli have lost their function. Atherosclerosis accelerates the decrease of renal size with age. Physiologic changes in the aging kidney include decreased renal blood flow, due in part to atherosclerosis, resulting in a decreased GFR. Changes in hormone levels, including ADH, aldosterone, ANP, result in decreased urinary concentrating ability and changes in the excretion of water, sodium, potassium, and acid. Despite these changes, older adults maintain homeostasis until they encounter diseases or other physiologic stressors. After abrupt changes in blood volume, acid load, or other insults, the kidney may not be able to function effectively because much of its renal reserve has been lost. Physiologic changes occur in the aging urethra and bladder. The female urethra, bladder, vagina, and pelvic floor undergo a loss of elasticity and muscle support. Consequently, older women are more prone to bladder infections and incontinence. The prostate surrounds the proximal urethra. As men age, the prostate enlarges and may affect urinary patterns, causing hesitancy, retention, slow stream, and bladder infections. Constipation, often experienced by older adults, can affect urination. Partial urethral obstruction may occur because of the rectum's close proximity to the urethra. Age-related changes in the urinary system and differences in assessment findings are outlined in Table 44.2. Assessment of urinary system. Subjective data. Important health information. Past health history. Ask the patient about the presence of history of kidney disease or other urologic problems. Note specific urinary problems such as cancer, infections, benign prostatic hyperplasia, BPH, and stones. Ask about other health problems that may affect kidney function, including hypertension, diabetes, gout, connective tissue disorders, e.g., systemic lupus, hepatitis, HIV, neurologic conditions, e.g., stroke, back injury, and trauma. Medications. An assessment of the patient's current and past use of medications is important. Include over-the-counter drugs, prescription drugs, and herbal therapies. Drugs affect the urinary tract in several ways. Many drugs can be nephrotoxic. Certain drugs may alter the quantity and character of urine output, e.g., diuretics. Several drugs change the color of urine. Pyridium turns urine orange. Nitrofurantoin, macrodantin, turns urine dark yellow to brown. Anticoagulants may cause hematuria. Many antidepressants, calcium channel blockers, antihistamines, and drugs used for neurologic and musculoskeletal disorders affect the ability of the bladder or sphincter to contract or relax normally. Surgery or other treatments. Ask the patient about hospitalizations related to renal or urologic diseases and all urinary problems during past pregnancies. Inquire about the duration, severity, and patient's perception of any problem and its treatment. Document past surgeries, especially pelvic surgeries, and urinary tract instrumentation, e.g., catheterization. Ask the patient about any radiation or chemotherapy treatment for cancer. Functional health patterns. Key questions to ask a patient with problems related to the renal system are listed in Table 44.4. Health perception, health management pattern. Ask about the patient's general health. Abnormal kidney function may be suspected if the patient reports changes in weight or appetite. Excess thirst, fluid retention, headache, pruritus, blurred vision, or feeling tired all the time. An older adult may report malaise and non-localized abdominal discomfort as the only symptoms of a UTI. In older adults with UTI, family members may report the patient is disoriented, has fallen, or has increased confusion. Obtain a smoking history. Cigarette smoking is a major risk factor for bladder and kidney cancer. Smokers who also work with cancer-causing chemicals have an especially high risk for bladder cancer. Exposure to certain chemicals can affect the urinary system. Aromatic amines and some organic chemicals increase the risk for bladder cancer. Phenol and ethylene glycol are examples of nephrotoxic chemicals. Obtain an occupational history. Machinists, painters, hairdressers, printers, and truck drivers have an increased incidence of bladder cancer. Information about places where a patient has lived is important. Persons living in the southeast part of the United States have the highest incidence of urinary stones. This may be caused by the higher mineral content of the soil and water. A person living in Middle Eastern countries or Africa can acquire certain parasites that can cause cystitis or bladder cancer. Nutritional metabolic pattern. The usual quantity and types of fluid a patient drinks are important in relation to urinary tract disease. Dehydration may contribute to UTIs, stone formation, and kidney failure. Large intake of specific foods, such as dairy products or foods high in proteins, may lead to stone formation. Asparagus may cause the urine to smell musty. Red urine caused by beet ingestion may be mistaken for bloody urine. Caffeine, alcohol, carbonated beverages, some artificial sweeteners, or spicy foods often worsen urinary inflammatory diseases. Green tea and some herbal teas cause diuresis. An unexplained weight gain may be a result of fluid retention from a kidney problem. Anorexia, nausea, and vomiting can dramatically affect fluid status and require careful monitoring. Elimination pattern. Questions about urine elimination patterns are the cornerstone of the health history in the patient with a lower urinary tract disorder. Begin with asking how the patient manages urine elimination. Ask about daytime, diurnal, voiding frequency, and the frequency of nocturia. Pelvic organ prolapses, particularly advanced anterior vaginal prolapse, may cause suprapubic pressure, frequency, urgency, and incontinence from urinary retention. Ask about other bothersome lower urinary tract symptoms, including urgency, incontinence, or urinary retention. Changes in the color and appearance of urine are often significant and need evaluated. If blood is visible in the urine, determine if it occurs at the beginning of, throughout, or at the end of urination. This is harder for the female patient. Assess bowel function. Problems with fecal incontinence may signal neurologic causes for bladder problems because of shared nerve pathways. Constipation and fecal impaction can partially obstruct the urethra, causing inadequate bladder emptying, overflow incontinence, and infection. Determine the patient's method of managing a urinary problem. The patient may already be using a catheter or a collection device. Sometimes the patient must assume a specific position to urinate or perform maneuvers, such as pressing on the lower abdomen, Creed's method, or straining, Valsalva maneuver, to empty the bladder. Activity exercise pattern. Assess the patient's level of activity. A sedentary person is more likely to have stasis of urine than an active person and thus be predisposed to infection and stones. Demineralization of bones in a person with limited physical activity can cause increased urine calcium precipitation. An active person may find that increasing activity worsens the urinary problem. The patient who has had prostate surgery or who has had weakened pelvic floor muscles may leak urine when trying certain activities, such as running. Some men develop chronic inflammatory prostatitis or epididymitis after heavy lifting or long distance driving. Sleep rest pattern. Nocturia is a common and a particularly bothersome symptom that often leads to sleep deprivation, daytime sleepiness, and fatigue. It occurs in multiple problems affecting the lower urinary tract, including urinary incontinence, urinary retention, and interstitial cystitis. Nocturia may be related to polyuria from kidney disease, poorly controlled diabetes, alcohol use, excess fluid intake, liver disease, heart failure, or obstructive sleep apnea. When assessing nocturia, determine whether the need to urinate causes the person to arise from sleep or whether pain or other symptoms interrupt sleep. Ask if the person urinates as a matter of habit before returning to bed. Up to one episode of nocturia is considered normal in younger adults, and up to 2 episodes are acceptable in adults ages 65 years or older. If an older adult has more than 2 episodes during the night, assess the amount and timing of fluid intake. This information will help determine whether further investigation is needed. Cognitive perceptual pattern. Assess the level of mobility, visual acuity, and dexterity. These are important factors to evaluate in a patient with urologic problems. especially when urine retention or incontinence is a problem. Determine if the patient is alert, understands instructions, and can recall instructions when needed. If urinary incontinence is present, ask how the patient is managing the problem. Recognize that incontinence is often distressing and embarrassing. Discuss the problem with the patient with sensitivity in a non-judgmental manner. A frequent symptom of renal and urologic problems is pain, including dysuria, groin pain, costovertebral pain, and suprapubic pain. Assess pain and document the location, character, and duration. The absence of pain when other urinary symptoms exist is significant. Many urinary tract cancers are painless in the early stages. Self-perception, self-concept pattern. Problems associated with the urinary system, such as incontinence, urinary diversion procedures, and chronic fatigue, may occur with anemia, can result in loss of self-esteem and a negative body image. Role relationship pattern. Urinary problems can affect many aspects of a person's life, including the ability to work and relationships with others. These factors have important implications for future treatment and management of the patient's condition. Urinary system problems may be serious enough to cause problems in job-related and social situations. Chronic dialysis therapy often makes regular employment or management of home and family responsibilities difficult. Concurrent poor health and negative body image can seriously affect existing roles. Sexuality reproductive pattern. Assess the effect of renal problems on the patient's sexual satisfaction. Problems related to personal hygiene and fatigue can negatively affect sexual relationships. Although urinary incontinence is not directly associated with sexual dysfunction, it often has a devastating effect on self-esteem and social and intimate relationships. Counseling both the patient and partner may be needed. Objective data. Physical examination. Inspection. Assess for changes in the following: skin, pallor, yellow-gray cast, excoriations, change in turgor, bruises, texture, e.g. rough, dry skin. Mouth, stomatitis, ammonia breath odor. Face and extremities, generalized edema, peripheral edema. Abdomen, abdominal contour for midline mass in lower abdomen may indicate bladder distension and urinary retention, or unilateral mass, sometimes seen in adults, indicating kidney enlargement from large tumor or polycystic kidney. Weight gained from edema, weight loss, and muscle wasting in kidney failure. General state of health, fatigue, lethargy, and decreased alertness. Palpation. The kidneys are posterior organs protected by the abdominal organs, ribs, and heavy back muscles. A landmark useful in locating the kidneys is the costovertebral angle, CVA, formed by the rib cage and the vertebral column. The normal-sized left kidney is rarely palpable because the spleen lies directly on top of it. Occasionally, the lower pole of the right kidney is palpable. To palpate the right kidney, place your left anterior hand behind and support the patient's right side between the rib cage and the iliac crest. Elevate the right flank with the left hand. Use your right hand to palpate deeply for the right kidney. The lower pole of the right kidney may be felt as a smooth, rounded mass that descends on inspiration. If the kidney is palpable, note its size, contour, and tenderness. Kidney enlargement is suggestive of cancer or other serious renal pathologic conditions. The urinary bladder is normally not palpable unless it is distended with urine. If the bladder is full, it may be felt as a smooth, round, firm organ and is sensitive to palpation. Percussion. Tenderness in the flank area may be detected by fist percussion, kidney punch. This technique is performed by striking the fist of one hand against the dorsal surface of the other hand, which is placed flat along the posterior CVA margin. Normally, this type of percussion should not elicit pain. If CVA tenderness and pain are present, may indicate a kidney infection or polycystic kidney disease. A bladder does not percuss until it contains at least 150 milliliters of urine. If the bladder is full, dullness is heard above the symphysis pubis. A distended bladder may be percussed as high as the umbilicus. Auscultation. Use the diaphragm of the stethoscope to auscultate bowel sounds, since the bowels can affect the urinary system. Use a focused assessment to evaluate the status of previously identified urinary system problems and to monitor for signs of new problems. A focused assessment of the urinary system is outlined in the box on this page. Diagnostic studies of urinary system. Many diagnostic studies are used to assess problems of the urinary system. Tables blah 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 describe the most common studies. Select studies are described in more detail here. Many radiologic studies require the use of a bowel preparation the evening before the study to clear the lower GI tract of feces and flatus. Because the kidneys live in a retroperitoneal location, colon contents can obstruct visualization of the urinary tract. If the bowel prep does not adequately clear the lower GI tract, the study may be unsuccessful and need rescheduled. Common bowel prep includes enemas, magnesium citrate, and bisacodyl dulcolax, tablets or suppositories. Patients with kidney failure should not receive some bowel preps, such as magnesium citrate and fleet enema, because the kidneys cannot excrete the magnesium. Iodine-based contrast media used in some diagnostic studies may cause contrast-induced kidney injury, CIN, and allergic reactions. Keeping the patient hydrated is important. Some patients may need IV fluids start hours before the procedure. N-acetylcysteine, a renal vasodilator and antioxidant, is sometimes given to reduce the incidence of CIN. Can be given by oral or IV route. When a patient has multiple diagnostic studies, it is important to maintain hydration. The patient is at risk for dehydration when they have had nothing by mouth for consecutive days, extended time in the radiology department, and bowel preparations. Severe dehydration, especially in debilitated or older patients and patients with diabetes, may lead to acute kidney injury. Ensure that the patient is properly hydrated and given adequate nourishment between studies. Check with the HCP about insulin dosage for patients with diabetes who are NPO. Urine studies. Urinalysis. Urinalysis is one of the first studies done to evaluate disorders of the urinary tract. Results from urinalysis may show abnormalities, suggest the need for further studies, or show progression in a previously diagnosed disorder. Although a specimen may be collected at any time of the day for routine urinalysis, it is best to obtain the first specimen urinated in the morning. This concentrated specimen is more likely to contain abnormal constituents if they are present in the urine. The specimen should be examined within 1 hour of urinating. Otherwise, bacteria multiply rapidly, RBCs hemolyze, casts, molds of renal tubules, disintegrate, and the urine becomes alkaline because of urea-splitting bacteria. If it is not possible to send the specimen to the laboratory immediately, refrigerate it. However, for best results, coordinate specimen collection with routine laboratory hours. Creatinine clearance. A common test used to analyze urinary system disorders is creatinine clearance. Creatinine is a waste product made by muscle breakdown. Urinary excretion of creatinine is a measure of the amount of active muscle tissues in the body, not of body weight. Therefore, people with larger muscle mass have higher values. Because almost all creatinine in the blood is normally excreted by the kidneys, creatinine clearance is the most accurate indicator of renal function. The result of a creatinine clearance test closely approximates that of the GFR. A blood specimen to measure serum creatinine should be obtained during the period of urine collection. Creatinine levels stay remarkably constant for each person because they are not significantly affected by protein ingestion, muscular exercise, water intake, or rate of urine production. Normal creatinine clearance values range from 87 to 139 milliliters per minute. After age 40, the creatinine clearance rate decreases at a rate of about 1 milliliter per minute per year. Urodynamic studies. Urodynamic studies measure urinary tract function. Urodynamic tests study the storage of urine within the bladder and the flow of urine through the urinary tract to the outside of the body. A combination of techniques may be used for a detailed assessment of urinary function.